Okay, here is something that you need to know. In the rare occasion, it's not rare. Let me take this back. In the test, if you see safe planning right here, safety planning, that is high yield. Can you guys see a safety plan here? If you see on the test, safety contract, never pick a safety contract. So what is a safety planning? A safety planning, it was done by Dr. Brown, if I'm not mistaken, is a stepwise de-escalation of crisis. Think of it as fire drill. We drill in case if a fire happens. That is the same knowledge for safety planning, right? We can go at the end we can go through a safety planning together so you guys can see how that can be useful. Some
Can I ask a quick
studies
question, Dr. Lopez?
suggest that it decreased up to 70% from suicidality. If you want to implement a cool project in your hospital, talk to the ED department and ask them to implement a safety planning. Provide what I did before. I collect the data from the hospital, the entire hospital in a region for the year. Then I provided the education safety planning, and then I collected the data in the future, and then I compare. If my education was effective, then the numbers of suicidal calls or readmission would decrease. That would be my hypothesis, right? And they saw it play out that way. But some studies suggest up to 70% decrease in suicidality or at least attempts. Okay.
Can I ask a quick question, Dr.
Go
Lopez?
ahead, please. Yes.
Like regarding that patient, because he had a suicide note, a plan, obviously intent, and if he went home and committed suicide, wouldn't I be liable for that?
No. You know,
He
it's a great
disclosed
question.
everything?
It's a great question. One of my biggest fear coming from critical care to psychiatry is what if the patient kills themselves? So I had a session with the mental health provider, a psychiatrist, and said, look, you're doing all you can with all the information that you have. You do not have the power or control over your patients. You provide the education, you provide the guidance, you de-escalate the situation. Now the patients have the freedom to choose their outcome, right? But a safety planning that would be your backup in court. The day the patient presented, we conducted safety planning. The patient understood the risks involved and the benefits of the safety planning. As he left the office, we touched base on his current mood and so forth, right? As long as you documented that you've done what you need to do, it will be an investigation, okay? That is no doubt. But your documentation with the safety planning, that you review the safety planning during this encounter, and now one that has not been reviewed for 6 months will support what you did, right? Plus, you got to look in a safety plan. What are you looking for? Step number 6. Do you have a gun in the house? Do you have medications all over the cabinet? Are you taking benzos, something that could kill, right? So these are part of the safety planning. It really is a very nice tool to use. We can probably run over one at the end of today's event, if you guys want to. Okay. Our next question. The question you need to ask yourself, what is the recovery model? And the recovery model, nothing but learning from your experiences, knowing that there will be setbacks, and we learn from that, right? There is no better opportunity to learn from failures. When we fail, we pick up ourselves again, and we learn from that what worked, what it didn't, and we try not to fall in the same pitfalls, right? Here's the rationale. The recovery model views setbacks as opportunities for learning and adjustment. Anytime you hear recovery model, think of it as opportunities for learning and adjustments from the experience, right? This aligns with the recovery model, emphasizes explorations and adaptation. Okay, so you have to maintain your boundaries of professionalism, right? I know everybody knows a story of someone that dated a patient somewhere, and most likely they lost their license. And this is even more true in psychiatry. You hold the power when someone is very vulnerable, right? It's very easy to be likable because you're providing comfort during a distress, right? So you have to really check yourself and maintain the barrier so that you don't fall in this trap, because it's very easy to like the patient as well. For example, yesterday, I was really thinking all night about one of my patients because my note would pretty much end his career, right? So I had to really think carefully what my note would say. Right, so no wonder he actually called me this morning, and we talked about it, what it means and what it does not mean for his career. So so look an example. Instead of calling the patient bipolar 2, what was my diagnosis then? Unspecified mood disorder, pending psychological testing to rule out or rule in bipolar, right? Because my word has a lot of weight, not just because of me, I'm not important, but any provider that puts someone as a bipolar, they, depending on what they do, it is Korean ending. So I could not, all night I was thinking about it. How can I go around and be sure the diagnosis is what it is, because someone just may lose their life earnings because of my note, right? So now, as far as professional, try to maintain a barrier, because that way you don't fall into the trap of liking someone, or because you became too friends with them. Okay, so it's important, try to decline it. Now, if you are in a shopping center, somebody says, "Hey, Dr. Lopez," I say, "Hi, how are you?" And I keep on moving, right? In my community, it's actually very easy. Sometimes I go to a party over a friend's house and I see my patient in the same party. I don't talk to the patient. I'll say hello, but we don't discuss any case or anything related to mental health, right? Even though they may try, you'd be like, oh, sorry. So that way it doesn't, the lines don't get blurred. Okay. So declining the patient's invitation and exploring the importance of maintaining professional boundaries. It is super important. It will save somebody's licensure. Okay.
Dr. Lopez, may I ask real quickly, is there like a timeline though?
We'll go back to this
After this
in a
question.
second.
Sorry.
Yes.
Sorry. Okay.
All right. Unfortunately, I missed this question here. Did anyone take a picture of the question by any chance?
Yes.
Okay, what did the question say? Could you kindly read it to me?
Yes. A Psych NP is conducting a therapy session with a patient who has recently experienced a traumatic event. The patient begins to cry and express intense emotions. Which therapeutic communication response by the Psych NP is most appropriate in this situation?
Okay. All right. And most of you guys got the red, and then let's compare to the green, right? Tell me more details about the traumatic event compared to, I'm sorry this happens to you. It must be really difficult. Here's the thing, guys. Never say that you understand what somebody else is going through if you have never been through, right? I don't know what's like to being raped. Never been raped. I don't know what's like to lose a mother, what a mother feels if she loses her baby. I never lost one of my child, and I never been a mother. So what can I say? I'm sorry it happened to you. It must be really hard, right? So that is a empathetic answer, right? So instead of, tell me more about the details of this traumatic event, right? So that is data gathering, but you're looking for an empathetic answer at this moment, right? The person may just want to be understood or have someone to listen to. Maybe she couldn't talk about the distress with her husband. I don't know what the distress is, right? But that would be an empathetic validation and support answer, right? So now, I think it was Mrs. Kim, she mentioned, is there a time in which a provider can date a former patient? What do you guys think about that?
Should be a couple of years at least, right?
No.
I don't
No.
know. I don't
It
know.
happens though.
No, for me,
It happens.
but I
Okay,
don't know.
Jacqueline, that's a good
Well,
discussion. So we're going to
it's-
actually talk a little bit about it, because Jacqueline, what do you have to say? Christine, do you have an answer there, or you want to make a comment?
What was the
How is-
question? What was the question?
The question was, we determined that it's unprofessional to date a patient, but is that a time that could be okay?
When you discharge the patient.
Okay.
There's no more
So,
conflict of interest.
okay, I want you to discharge the patient, but okay, I don't know if I agree
It
with
feels
that.
unethical. I don't know. Maybe
Yeah,
legally it's okay, but it feels unethical.
it does. So let's take a look what the ANA has to say, right? So ANA strictly prohibits romantic or sexual relationships between provider and the current patient. We got that. Okay. Now, yeah, I mean, anybody surprised? Of course, right? Now, as far as formal patient, right? So the situation is more of a nuance. Okay. Now, while there isn't any that I know of, a universal mandated timeline, I don't know, maybe it's state, I don't know all the states' regulations, right? But the guidelines suggest that a relationship with a formal patient may be considered unethical if the provider use or explore the trust of the patient. Again, one could look at it and say you would never have dated this patient had you not provide support, empathy, and care. So one could view that you used your power and abilities to manipulate, and I'm not saying that's the case, right? But one could make a case against you, I believe. Now, does it happen? All the time, right? All the time. I had a patient, a nurse, when they worked in ICU. I found out that later she was dating one of our patients, right? Or hanging out at the bar. Maybe okay, but it is considered unethical. There is so many people that you can date out there. Most likely your ex-patient or your former patient is not a good choice. I'm just saying, like we have billions of people that we could go out and date. Why date your patients?
I know a
wouldn't
nurse
risk it.
that married a former patient, and
Oh
that's how she
yeah.
met him.
Yeah, no,
Interesting
absolutely.
discussion. Thank you so
Yeah,
much.
no.
I was just curious because I know of several instances where that
Oh yeah.
happened.
I mean, who's going to stop and sue the provider and so forth? But now, wait. What if they marry and later he or she comes back and say, I married him or her, because we met during psychiatry, he provided support. That can be a strong case if it goes to court, right?
Right.
We never know. We never know. And we know when we break up, we probably want to break up. We don't want to be friends with ex most of the time. I mean, it's
Right.
true, right? There's a reason why we had to break up. It's because we don't want to be friends anymore. And people act in anger when they're breaking up, and they may use that against you to hurt you. I mean, I
Dr.
would imagine
Lopez,
that would be a case of somebody that did that. I don't know if it is actually a case.
Dr. Lopez, I was part of the administration from my hospital ethics
Mm.
team, and we had a nurse that had that, and we had to make the decision to let her go. And this is after marriage.
Yeah, I mean, money talks, shortage of professional talks. There is a lot of considerations, and the reputation of the hospital matters the most, right? So if this becomes the news, how would the hospital be viewed?
And it's even worse because it was in a military setting, because I work in a military setting. So that was definitely a no-no.
Yep.
Interesting discussion. Thank you.
Mm-hmm. All right, so I trust everyone will get this question right. Specifically, if you attended yesterday's or this week module 2. Okay, almost everyone got it right? So what is the purpose of SEWA, right? Why do we do SEWA? There is a purpose, right? Is to assess the severity of the alcohol withdrawal. Hey, your number when I assess in SEWA is 8 or 9. What do we do then?
You give a PRN.
PRN what? What medication?
Lorazepam or diazepam, but
Okay. Now let's say that in this scenario, I'm gonna call his ALT is 55, his AST is 60. What medication would you use for this patient?
Lorazepam.
Somebody said diazepam?
Lorazepam.
Lorazepam, okay?
Yes.
All right, great. Okay. So here we have it. Now let's take since we are here and this is an alcohol use question, let's take a look on the PDF from module 2 and kind of like just review this content very fast, less than a minute, okay? So let's see if we can just do that real quick and then we'll get back to the game.
While you look that up, the other, since we were talking about how through either marriage or relationship, if anybody is ever interested in reading a book that's actually based on a story, it's Siren's Dance, My Marriage to a Borderline, a case study. So a doctor who was a med student fell for someone who had attempted suicide. So they had started a relationship thereafter. He wrote a book about being married, I think either for a year or two, and then of course divorce, but talking about it and how he used it as his case study. So just throwing that out there.
Yeah, I mean, poor borderline patients. I mean, that's very hard too, right? So here we have we talked about, let me see, where is that at? The suicidality. Here we go. So SEWA is highlighted 8, start PRN only. If it's 15 or more, PRN plus the scheduled medication, right? The 2 medications that we prefer is lorazepam if the patient has liver disease like hepatitis or the labs suggest a liver insult, right? And we talked about the 3 medications that we give for alcohol maintenance, right? Which is then disulfiram, acamprosate, and naltrexone. Now, if you are new provider, never give naltrexone, never give Vivitrol right away. One, it doesn't matter, one, it's very expensive. But what matters is Vivitrol is an injectable, right? So you're gonna give it a little, you're gonna give it in a butt, right? And it has to be, you have to know how to give it. That's 1. And 2, it is injectable. So why not give it right away if it's one of the best? And we know that the patient took it and now they should have less of a decrease in craving. Okay, so ask yourself, what would happen if the patient is allergic to Vivitrol? Would you know? No, you wouldn't know because the patient never took this medication before. Now, you just bought this patient intubation, possibly for a few days in ICU, right? And I see this mistake as one of the most grave mistakes that I have seen in psychiatry. New provider, MD, PMHNP, I never seen a pharmacist making this mistake, but be on a watch out, and that is the reason why. We also talked about that alcohol withdrawal. It is very dangerous, right? Because it lowers the seizure threshold. What other medications lower the seizure threshold?
Wellbutrin.
Wellbutrin, right? Now, also, stimulants can almost induce seizures too. So now think about an ADHD patient that stopped drinking and maybe taking Wellbutrin, right? That is the second most mistake, a common mistake that I've seen is providing providers and often MDs giving the patient Wellbutrin right after the detox when they're not drinking, just because it's not given. The patient was already on this medication, but now the patient is going through a detox. Are you going to continue the medication right away? It's probably best not to, because one, they stop drinking, they're going through a withdrawal, they're more likely to go into a seizure, and two, by having the Wellbutrin either started or continue, it could also aggravate the situation.
Transopine.
Okay. All right. So next question here. Let's get started or stop sharing. If I see something that is a topic that we covered yesterday, we'll go ahead and stop for a second and do a little bit of a teaching. And after this question, we'll go ahead and answer those folks that have a question. So please hold your question and we'll go back to you after this one. So everyone should get this one right as well, right? What is the question really asking you? Okay, so I can never forget this. This is like, I don't know why, I can never forget this. Dr. Lopez, on the test, I got confused between cows and Siwa. And I hope if you picked clonidine, you are not making this mistake that somebody made almost 3 years ago. And I'm like, how can you forget between or get confused cows with Siwa? So it's good that you made this mistake now. It's really good. It's not bad. Because now you learn not to confuse cow with Siwa. Okay? Now, we just went over a second ago, and I showed you guys this, the 3 medication for alcohol maintenance. That's another point of confusion. Are you going to give naltrexone, acamprosate, anti-abuse, disulfiram for someone going through withdrawal? No. Right? So that is the second point of confusion. 2 points that people always get them mixed up. Somebody will. So please learn from your mistakes today and don't get this confused, because that can be easily a 2-3 questions on your test. Okay, so let's see the rationale and then we'll stop for a second just to, 23 players have reached 6 answers streak. Awesome. Now look at the rationale, and while you look at that, let me see who has questions here. Let me see. Christine, do you have a question? Okay.
Oh no, I don't. Sorry,
okay,
error.
No problem. Hard dip. Do you have a hard dip? Do you have a question? Yes.
I'm
good, thank you.
Good. Okay. Stella, if you guys don't have a question, just lower your hand. Okay, check. Okay. Stella, do you have a question?
Yes, doctor. I cannot play with you guys. I'm just putting my answer here because I came late. I'm trying to log from here. I can't get in.
Okay, no worries. We'll catch you next time. No worries. Nikish?
Dr. Lopez, the scoring board, I don't think is right, because
if you get a straight 5 answers and some people theirs has already jumped, is it from previous time? Because I don't know what the scoring board is the one.
Yeah, so you know your score, but you don't know others' scores. So it could be that others, if you came late, they're gonna have an advantage on you, right? Because they answer more questions. That's one for sure. Now we don't know how well other people are doing. We only know ourselves, and at the end they'll show you your score. Okay, Jacqueline, do you have a question there?
And also, if you answer the faster you answer, it push you at the top.
Yes, the faster you answer, it pushes you to the top. All right. All right. So go ahead and lower there. I believe hard dip. Do you have a question? If not, we'll go on to the next one. Okay, moving on.
Next question.
Next question. All right. So before I answer this, let's go back to the PDF one more time, real quick. Okay. And this is right out from the PDF. So you understand how important the PDF is, right? This is right here. So everyone should really get this one right if you are in the course, obviously. Now, a compensating naltrexone, can you guys see that? The research has shown that it reduces alcohol consumption and days of abstinence. Okay, so now in regards to the sulfaram, it is in a therapy aversion, meaning that if you drink, you will be sick, right? But in regards to a compensating naltrexone, 2 things to remember: reduce alcohol consumption, meaning if the patient had 10 drinks, now if they decide to drink again, they may have 3, because what happened is that alcohol doesn't provide it's as much, it still does, as much as its pleasure. It takes the pleasure away. So it reduces the consumption, and the days that patients been without drinking may increase. And this is what we want, okay? So this is right from our slide. So always keep reading the slides, print them out, and then kind of revising the stuff that we were going through, okay? All right, so here we got, let's take a look on the rationale now. Well, congratulations to those 5 players, really taking the lead. So a compensate, right, specifically indicated for reducing alcohol craving, not maintenance, not withdrawal, and help abstinence by restoring balance in the brain neurotransmitter system, right? Okay, anti-abuse, it is a works by aversion, right? So patients will be scared of drinking. So some patients, not some, I had few, it's like, I need anti-abuse, and I ask them why. Because I need somebody to check on me. If I am just going on my willpower, eventually I will be like, oh, okay, it's just 1 drink. So anti-abuse does that. It's like, if you drink it, there is no forgiving, right? You pay the price. For some people, it works. Okay. But make sure you're checking the liver enzymes for anti-abuse. All right, so this is a bit complicated, and I can see why some people pick the blue, right? The blue is a true statement. Okay, but is the blue avoid alcohol for at least 12 hours before taking the medication, right? So you took the medication 12 hours before, no alcohol. Now let's take a look on the green. Refrain from using anything that contains alcohol while taking this med. It is a much more important direction because the patient's eating a salad dressing or using perfume or using any product that contains alcohol. It's almost as dangerous as drinking the alcohol. But on the test, you probably wouldn't have these two true statements. So if even though the green is a better answer, the blue still is a correct statement. Now, can consume alcohol safely while taking the sufferin if done in moderation? Absolutely not, unless if you want the patient to die of dehydration by vomiting and feeling super bad. No alcohol whatsoever in any shape or form. Now the question is, okay, your patient stopped taking the sufferin today. How long does he need to wait until he can have a drink or drink a salad dressed with alcohol?
2 weeks.
Just
2
2
weeks.
weeks. 2
2
weeks.
weeks. So what you need to remember is the sufferin 12 hours before, 2 weeks after, alcohol aversion, right? And this education is likely to be asked because people often don't think that a salad dress contains alcohol or that a perfume or deodorant contains alcohol. Some people think they don't, or they never stop to think because we just eat it, use it, and never stop to think. But if the patient is taking this medication, they will pay a high price. Okay, the very important teaching moment there. All right, who remembers that I was yawning, right? I'm like, So remember, muscle wake and renal hair, not galactohair, renal hair, diarrhea, anything that's watery and yawning, it is alcohol, opioids withdrawal. Okay.
Yeah,
so
doctor,
the
the
Oh,
question got it marked
Answer
wrong.
is wrong.
Yeah.
oh, sorry. Yeah, it
Yeah.
was
I'm like,
Give me
my,
no
my, it's my
way. I
winning
know
yeah.
star.
I
better.
was like, what?
Only one person is
I
right.
was in the lead. It dropped
Yeah,
me.
sorry. So whoever got the extra point here got a for free on this
That's
one.
not
Okay.
fair.
All right.
man.
Good
So it's
job.
muscle ache, yawning. So you got it wrong, but you
Got
got
it
it
right.
right. So yeah, it happens, man. You know, what can I say?
I went from 7 to 41.
Yeah, somebody got an extra point. They're like, yeah, you know, sometimes that happens too. So now let's take a look. Now we'll keep on going because just for the sake of the game. Otherwise, we can do more teaching after. Okay. Ooh, we talked about frames before. Anybody surprised? There's a feedback here. Let's take a look here. What did they say? Okay, 1 second. Okay, frame models, the F stand for feedback, right? Is the component focused on providing objective feedback to the patient and their substance use, its consequence and potential risk. Feedback can increase the patient's awareness and motivation for change. It is a hard one, right? The R stands for responsibility. And remember, you have to know frames what it stands each of the letter. A stands for advice. Remember the M, menu of choices, right? And the E is for empathy, which involves showing understanding, empathy, and support for the patient's feelings and experience. While empathy is crucial for building rapport, it may not be the primary component for increasing motivation. So it is a very hard question, okay? I would almost very, if not, so empathy is a very strong answer, right? So usually it's non-judgmental, which helps build trust. But you're looking here for, you're looking more for component that provides feedback to the patient and helps aids in motivation, right? Just by understanding, oh, I understand what you're going through. Is that motivational, right? If during a process of motivation, do we provide advice? No, we listen. We listen, right? We listen. And later, if it's asked, then we provide advice. So that is the part of the feedback here that I'm mentioning, is part of the listening, right? But it is a very hard question, okay? Because it can be interpreted in different ways.
Was the answer feedback?
Yes.
Okay.
Okay, so let's take a look here. So do you ever drink every day? It's not necessarily part of the question, right? The CAGE questionnaire focused on assessing the presence of certain behaviors and feelings related to the alcohol use rather than use the frequency of drinking. Remember, CBERT, we use dust for drug usage. We use audit for alcohol, and we can also use CAGE. CAGE, it is a 4-question in which 2 or more answers positive would indicate further assessment is needed. We would explore a little bit more. Audit is more complex and is a 10-question and provides a lot more feedback.
I always guess those 2 questions are correct. I don't know.
It's a hard question too, right? Remember, we gotta know CAGE by the letter, frame, and craft, right? Yes, my teenager frequently gets in trouble at home when they drink, right? So that would be the most concerning out of those 4 answers there. Right? Teenagers frequently get in trouble at home when they drink suggests a pattern of problematic alcohol usage that can have negative consequences on their families and for themselves. Right? Okay. All right, so everybody got this right? So the 3 levels of prevention. When tests ask the 3 levels of prevention, the first thing that they will always do is make up the 4th level. That's the first thing you need to kind of be cognitive of. Well, it's A, B, C, D. They got to make up 1 answer every single time, every single test, right? And I like to make up something that's very confusing, because the people that don't know, they just smell like, oh, that makes sense, right? So if we say primary level of prevention, we are concerned about the P for primary, for prevention, right? And prevention meaning education, right? You want to prevent the problem from happening. Secondary, S of secondary is for screening, okay? And that could include screening the blood pressure, right? It could include calling the suicidality hotline, the veterans hotline for suicidality. It could be, maybe even administrating a medication the first time. Now, the third level is tertiary, meaning for rehabilitation, right? When someone is doing PT, OT, is doing like medication management long-term to get better, okay? So remember the 3 levels of prevention, they are important. Look for more examples on the 3 levels of prevention, because this is a very common question on tests in general. Okay, all right. Anyone, if you want to, and you do not have to, all right, absolutely do not have to. Anyone care to explain what was your rationale for secondary prevention?
I chose secondary prevention because I can't remember the question right now, but it seemed like to me that the children had already experienced whatever type of mental health disorder they was having. I don't know.
Okay.
They had already expended, and so what I was doing was providing them information on how to be resilient or deal with the mental health disorder. So it wouldn't be primary if they've already experienced the mental health disorder.
Yeah, so I like your rationale, but did the question say that it was they already suffer? It never said that.
Yeah. It said what now?
It didn't necessarily say that they went through a crisis and now is a crisis control. So secondary
No,
is
it sounds like that they already had something going on mentally. They had already.
It almost tricked me too, because it said maintaining the well-being, like maintaining the well-being or something, but I almost picked it, but then I seen it said prevent right behind it, so that's why I picked primary.
Good explanation. At the end of the question said that as well, right?
Okay.
Now I'm glad that but thank you, Mavis. This is a very important rationale, but it's good that some of you guys got incorrect now to be more acutely aware of the question. Now, I'm very happy that nobody picked protective factorial prevention, because that doesn't exist. Okay, so remember, on questions of primary, secondary, and tertiary, always, every single time, they will make up something that sounds good. Never pick anything that sounds good that you never heard of. Remember, the test is gold standard. There is no the new machine, the new drug. No, that's not going to be on your test because it's the gold standard. If you never heard as a psychiatric mental health nurse practitioner about to be, do not pick that answer. Okay, and we know we have to make up one to make it 4 answers, right? So always primary, secondary, tertiary. Okay, Be on a watch out for calling crisis hotline. Is that primary or secondary or tertiary?
Secondary.
Secondary, very common, right? Smoking cessation, is that primary, secondary?
Secondary.
Secondary.
Okay. Now, if we do perhaps, hold on, guys. So, okay. So if we do medication management long-term, would that be primary, secondary, or tertiary?
Tertiary.
Tertiary, okay. All right, so everyone should get these questions. Great. So tertiary focus on the reducing
I'm sorry, I have
the
a
impact.
question.
Go ahead.
So the one with smoking cessation, I heard primary and I heard secondary. What was the answer?
It depends. It depends. Were they already smoking? If it's sensation, meaning that they are already smoking. Now,
So
if
that's
it's
tertiary.
that, yes, but it is. This one is a hard one because if they're already smoking and let me put it this way. You cannot absolutely put in a line where it falls. We know we can take primary out. Now, is this the first time they're getting this smoke sensation? Right? So it's the beginning of the treatment. Just like you provide one-time medication for something else.
Oh,
Okay.
I see what you're saying. You
Yeah.
saying like if the person has never smoked before, and you
Then
give
it would be primary.
primary, yes.
Now, if it's a smoke sensation, you come over here the first time and you say, hey, I would like to quit smoking. I'll say, okay, let's do a smoking cessation in my office. Then now it's secondary. Now we can actually move this to tertiary if this is a continual, long-term rehabilitation for them not to smoke again. So it is a complicated one, the question.
Not understanding if
Yeah.
they already have the disease or the issue and you're providing an intervention, then it's tertiary. That's
Right.
my understanding.
Yes, but it's like how much of intervention are you providing? You got to take that in consideration too, because some questions can be is one time, just like, okay, you collecting a blood pressure and you prescribe the medication immediately, right? Now, if you're going to continue to prescribe, then it'll be more of a tertiary kind of answer. Hopefully, the tests will never put you in that kind of bind because it can be a bit complicated, and I can see where you're coming from for sure. Okay. All right. All right, so we're good here, right? Anytime you're doing motivational therapy, you should never be giving advice if they're not ready to receive, right? You should assess, and then when they are ready to receive, then you provide advice. If you find yourself trying to explain, trying to tell them this is best for you, this is not motivational, right? There would be something else, but not motivation. So when do you need to stop drinking is a direct confrontational statement, right? That would likely trigger a resistance. You should not touch the resistance point right? Let me tell you why quitting alcohol is essential. It's also confrontational, right? So how about what was the other one? I have a treatment plan ready for you. You give the patients a choice, right? Is a prescriptive approach that really removes the patient's autonomy, right? So as we can look at the correct answer, how do you feel about alcohol use, and what are your goals and dreams and exploration, right? Would feel motivation, understand where the person coming from, understand what their goals are, and how we can help them achieve those goals. All right, we got what? 15 seconds. Okay. 1 second here. 1 second, okay. Anybody remembers, anybody read the question again?
Yep, I can.
Anybody took a picture of this question?
Yeah. So during a therapy session, a patient expresses resistance to the idea of attending group therapy for their substance use disorder. The Psychiatric-Mental responds by saying, "It's important for you to have a say in your treatment choices, and I respect your autonomy. Let's explore your concerns about group therapy together." Which guiding principle of MI is the Psychiatric-Mental using in this interaction?
Okay. So let's say that the guiding principle of rolling with the resistant, it is this principle. But why? Instead of arguing with the patients or directly confronting their resistance, what it does is acknowledge the feelings and the autonomy. So it's rolling with the resistance of the patient, right? By stating, it is important that you have to say in your treatment choice, "I respect your autonomy," right? The PMHNP validates the person or the patient's perspective. The provider then shift from a confrontational stance to a collaborative by suggesting, "Hey, let's explore," what was that? "Let's explore your concerns about group therapies together." This approach is also avoids power struggles, okay? So empathy, right, is not necessarily the same thing as what the question was asking, okay? So rolling with the resistance would be the most correct answer, okay? So remember, anytime you are resisting or confronting the patient, is not motivational. But indeed, a hard question as well. Okay. But go ahead, please.
I was just going to say the word resistance is in the stem of the question.
Great.
So I think that also hints to Rollo's resistance was the correct answer.
That's an excellent observation for sure.
Thank you.
Yeah, absolutely. I mean, I forgot what the question was. I had someone had to read it for me so that I can think back to it. Okay, great. Next question. We're almost done for tonight. Nikisha, we'll go ahead. I can't stop right now, but we'll ask you your question immediately after, okay? This is a great question. Perfect. Okay. So in the pre-contemplation, I don't have a problem. What do you mean? I just killed the cat that was because the cat was running through the street very fast while I was driving drunk. I don't have a problem. It was an accident, right? So deny that there is a problem is the stage of pre-contemplation. Contemplation would be like, you know what? I've been drinking for a long time, and this is the second time it happened to me. Perhaps I should consider decreasing my drink. Preparation would be like, you know what? This is the second time it happens to me. It's not a coincidence. I am going to call AAA. Then action is I called AAA. I am going to the meetings. It has been less than 6 months that I've been attending those meetings. And now it goes to maintenance phase after 6 months. Okay?
And this is order my Matthew, bless my bread and my water. I thank you for your word. Jesus, amen.
You have a high mic, my dear. Christine, maybe. Okay, so that is the pre-contemplation, contemplation, preparation, and action. Remember the 6 months time frame for action, and then after that is maintenance. Nikish, you had a question earlier before I press next again. Do you mind sharing your thoughts?
No, I didn't have any question.
Oh, your hand is up.
Oh, let me raise it down. Thanks.
Okay. All right. And I think Hard Deep, did you have a question? Your hand is also up. Hard Deep. Okay, never mind. Moving
No,
on.
I don't. I don't know how to do it down.
Okay, I'll take it down. No worries.
Oh, I didn't even know we're starting.
All right, make sure you guys have your mics muted. Okay, we covered this in detail before, right? How do I know that the patient is ready for discharge? When the patient stop blaming others and assume responsibility for their actions, right? And that is true also for inpatients. And how do we know they're ready? They stop blaming the girlfriend, the boyfriend, you know, for what happened. They say, look, I also play a part in this, and I can see that how my interaction with the X and Y and Z person caused me to spiral, but I'm going to take control of what I can take control of, right? So that is an important concept in psychiatry. And if you got this one wrong, remember, make a note, because you might see this again somewhere. So it says here, I know it's my responsibility to manage them. That is the point that I convey during our classes, okay? Okay, we got, what, 2 more questions? If you are leading, make sure you keep leading. It's a very hard question, right, Joe? Let's take a look here on the rationale. Can you describe what steps have you taken to reduce cocaine use, right? So this question really assesses the preparation stage before it encourages the patient to discuss concrete steps that they have taken or planning to take to reduce their cocaine use. It aligns with the patient's readiness to make changes and actively plans for the behavior change. You guys remember what we said about cognitive behavior in both cognitive behavior therapy. So when we say cognitive therapy, it's just all about the mind, no behavior. When we say behavior therapy, it's all about the behavior that will take place for something to change, right? And when we marry behavior and cognitive and behavior together, then we have cognitive behavior therapy. So can someone give me some examples of behavior therapy?
Do you mean like CBT?
No, CBT is behavior and cognitive and behavior. So say it again.
Yeah.
Exposure, yes. What else?
Skill training and support.
Relaxation.
Skill training and support, relaxation, and problem solving, yes. Now all that, but remember one, that's all of that is very true. Say it again.
OCD?
OCD, no.
No.
But remember remodeling, right? Or modeling, right? So if you have a problem and someone's going through something, also kind of like being modeling before actually you have to talk to your boss about asking a salary increase, right? You can play that game like, well, let me pretend I'm your boss, walk in here and kind of go through that as well. Okay, modeling is important as well. Okay, but just want to kind of touch base on that. Now, since we're talking about cognitive and behavior therapy, what is the one thing that we should ask patients to do?
Journaling.
Journaling. Make sure you write that down. Journaling. And who is the father of cognitive behavior therapy? Or better known as Bareback. Okay. Now, do you guys remember what age? Not at what age, what score for Beckham?
1929.
1929 from yesterday, right? Since we connect Aaron Beckham, now the same thing. This is Beckham scales for major depressive disorder. I just want to see if you guys could remember, but right away, 1929.
That's the moderate scoring, correct?
Yes, the modern school. Yes, absolutely.
That's Grandma Beck's birthday.
Yes. Okay. I am so glad that somebody picked conduct generic tests predisposition for DBT. So what would that be? There is none.
Huntington's.
There is none. Never pick an answer that you never heard of. Never, never. Okay. Never pick an answer that's like, oh, I love this question that I have in one of my tests, and it's about, I think, mania or bipolar. And I put the same thing, conduct a generic test for bipolar. And like 30%, 40% of the students pick that because that's cool and fancy. It doesn't exist. Okay. So don't pick things that you never heard of. Don't doubt yourself. Trust the education that you're receiving. Right? If you never heard of, it's most likely not in your test. Okay. Now, as for what we need to know about DBT, who created DBT?
Masha.
What is the goal of DBT?
To reduce crisis.
Suicidality.
Okay. And obviously, what's the populations for borderline? And it is a very restrict environment. I believe it's 16 sections, and it's so restrictive that the therapist needs therapy as part of the program after the person completes a full session of DBT. Okay. And it is the gold standard for borderline personality disorder. They need very clear-cut instructions of what they need to do. Otherwise, it can be a very difficult day. Okay. What is the answer? To who created DBT? Marsha Lineham. I'm glad you asked, and I'm glad that you took a note, because you might see similar questions about who created DBT, who created cognitive behavior therapy. Okay, here's the one. Who created person-centered therapy?
Carl Rogers.
Rogers. What is the goal of person-centered therapy?
Self-actualization.
Love it.
And growth.
And growth, right? Because only humans can achieve self-actualization and growth. Okay, so these are important names. Okay, for you guys to remember. Awesome, absolutely awesome. So let's see who is the third place. DO2. Second place, Sweets. And first place is from George. All right. Hey guys, most important, then we got Michael and Laurie. Most important, all of you guys are champions, right? Because we all learned something today, no matter what is your position. Yeah, good job. So no matter what is your position today. So what does it mean? It doesn't mean that the person that, George is the smartest of the group. It could be, but it only means that George has prepared himself to this point. I'll bet some money that he did not score first time, which could be true, the first time he joined. It is a marathon. And as you progress, as you play, as you participate on the studies and each module, you get a little bit more stamina and knowledge. And one of the strongest indication that you will pass the board is achieving the podium, right? There is only 5 places there. That means it's very, very, very hard.
I'll say
very
this,
hard.
Dr. Lopez, I'll say this.
Go ahead.
Initially, when I first started this course, I was not on the podium, and today I'm on the podium. But I'll say that practicing questions, like constantly when I'm at work, like literally, I'm constantly doing questions. It forces you to think outside the box, or you feel like eliminate other responses that that are not appropriate.
Yeah, and that's why I say we are not putting.
Hello.
It's frozen.
I have lost connection. Giving
At
him
least
time
it
to come
happened at
back.
the end.
You guys are on your own.
Okay, guys, I have a question. So I just started and I'm not even done with my program yet. What was that last person he said? Paul Rogers?
Carl Rogers.
J.R.L. Rogers.
What
Yes.
therapy did he invent?
Humanistic.
Humanistic. A person
Humanistic.
centered.
Okay, because everybody talks at the
Patient-centered.
Person-centered therapy.
Yeah.
Yeah, so humanistic is the big umbrella in which person-centered therapy is right under, right? Some people would use interchart. They would call Carl Roger humanistic, but the most really correct is person-centered therapy. But it's not wrong if somebody says humanistic, okay? Because it's so close related to the, to the principle of humanistic that can be used, one can be named one or another. Okay. All right. So I just want to kind of follow up, and we'll do a little bit more questions about the program and how I find it that most students really absolutely ace the board. Every time you finish a module on your own, right? The recorded videos, make sure that week you are finishing all the questions bank related to that week. That is your homework, right? I feel like, oh, I really want to send everybody an email, remind them, but I don't want to be so annoying and kind of like sending emails reminders. But I really, really hope I'm looking at the question bank, see who logged in and who's actually doing the work, right? But if we finish module 2 this week, you really need to catch up with me, because next Tuesday, next Thursday, and Wednesday we'll be meeting up again for module 3. So you need to have completed your module 2 this week. And it is best if you are ahead of me, meaning, right, at some point you'll be at module 4 and I'll still be in module 3. So let's say you are module 4 now on your own, and you are attending module 2. That is perfect, because it's not on the same week, has been at least 10 days, 7 days since you visit module 2. So ideally, you should be ahead of me for the live classes and coming back to revisit the subject live. So that way you can count that as you study on your own, and the second time is just like, okay, I know this, please tell me something new. Right? Or at least a refresher of what you already know, right? So that way you are actively engaging and completing your question banks related to the module that you are currently at. We have people that just joined us yesterday maybe, and we have people that are testing tomorrow, right? So there is all this big umbrella where everybody is. But the message that I want to give to you guys is, if you finish a module, complete the question bank related to the module, and then come to the live classes so we can talk, we can answer questions that are unclear, we can discuss different things and learn from each other. Okay.
Dr. Lopez.
Yes.
Quick question.
Yes.
The PMHNP question bank, the first set, which is the PMHNP, the scientific, the advanced diagnostics, the sets below there, the second set, like the domain, those questions, some of those questions I'm having a lot of difficulty with, because I don't think I'm covering those questions in the module. I don't see them.
Right. You are right. But here's the thing. Imagine if I had to cover every subject. We would be on this course for years. So it is supposed to de-stress you and give you knowledge at the same time. So don't just kind of go with the flow and learn from the question, meaning that they are not as high yield as the first set, but there is still a point that you can pick up here and there. The second point about that is that it's very broad, which meaning it could be very useful for your ANC as well. In total, there are what, 1,500 questions or more. That means if you completed that once, you'll be super good. If you complete it twice, you'll be unstoppable. There is not a question on the board that they can ask you that you haven't never heard of, or you have no clue how to answer. It could be that you get it wrong, but you have a good rationale for why you picked the question. We have 1,500 questions that is available for you to practice. So hopefully you kind of understand that what big box companies do. They're going to cover everything. Well, covering everything is not good for the test, because who needs to be covered everything? You don't need to be reading a book that this thick. You need to know high yield content and a way to remember. So we can't cover absolutely everything, but what we cover is more than enough, 90% of what you need to pass, for sure.
Okay.
Okay. All right.
Thank you.
Absolutely. So, Marta, do you have a question? If not, Tamara, do you have a question?
Question.
Hi, Marta.
Hi, Doug.
Hi, how can I help you?
Yeah, I had a question I put on the chat. Let me see.
Oh.
1 minute.
Okay.
I think I lost it.
Okay, while you look, I'll be answering the other questions. You come back, okay,
I
Marta?
got it.
Okay, go ahead, please.
So the question was asking, a patient with the Lewy body dementia experiencing worsening hallucinations, which medication is most effective to add? And then the option was Alcept, Namenda, Seroquel, or Rifastriline. So it's just cracking my head.
Okay, so Lewy body, I'm seeing things to help you remember. Hallucination is part of the disease process. So when you hear Lewy body, you're like, whoa, hallucinations, right? We do not give antipsychotics to Lewy body. So out of the two options, A and B, which one is antipsychotic?
Seroquel.
Seroquel.
Seroquel. So are you going to give a Seroquel?
No.
No. So then you have your answer, right? Aricept, which was A.
Oh, okay.
All righty. Good question, though.
Thank you.
So, guys, that's a very good question, right? It's a very high yield question, right? Because if you don't know that, first thing you would want to pick is an antipsychotic because of the hallucination, okay? So never go to sleep without asking your question, okay? You really need to kind of ask the question so that you feel that you have a good preparation, all right? Tamara, do you have a question?
Hey, Dr. Lopez. Yeah.
Hello there. Hi.
So my question is this. It's going back to the brainscape. I guess my question is, if we have all your PDF and we have downloaded them, using those as a study method, how much more effective is the brainscape versus your lectures and PDFs?
So it is a personal decision, but what I can tell you is that we spend a lot of time on our phones, and even at work, I could be scrolling down for 10 minutes and entertaining myself. Now, think about if you're like having lunch at work and you could just scroll it and kind of like review the material, module 1 in 10 minutes. Would that be helpful to you? Now, the second thing is that when you are doing the PDF, you're not going to go straight on the topic number 23, right? You're going to review from the beginning to the end, and that's going to take time. With the brainscape, the idea behind the brainscape is that you number things that you know and number things that you don't know. Let's say if you know things really good, you press a 5. If you don't know, you press 1. So the machine learns that, hey, you need help with the 1s and not the 5s. So it's going to show you the 1s more often. So basically, studying effective is studying what you need to know and not studying everything from the beginning every single time. That is how medical students usually study, okay, with something called ANCC. It's the same technology as Brainscape, but it is a free out there. It is cumbersome to use. Brainscape, there is support. You can call the support if something's not right. You know, there is a little bit more user-friendly because it's paid for. So it is a personal choice. I don't necessarily think I would use it. I use it for everything that I do, right? If I am learning a new material, or let's say 50 different drugs, and I'm going to give a presentation for whatever, about 50 different drugs, I might want to put them on my Brainscape and be like, right? So it is helpful, but maybe not for everybody, but I think it's super, super helpful. Okay.
All right, thank you.
Absolutely. So it's a choice. You know, if you're comfortable with going through the PDFs, as long as you are going through the PDF every day or every other day, or at least reviewing the material that you cover before you advance to module 3 or 4 and coming back to modules 1, 2, and 3, that is also very effective. Okay. Alrighty. Diane, do you have a question?
I do.
Hi.
Hi. So yesterday you were going over, you highlighted some material that somebody who just took the exam recommended. I'm very new to the group. What was that from?
So that is the crash course review.
And is that something that we have access to, or is that an extra purchase? Like, do we have to?
Nope. You don't have to purchase anything if you took the PMHNP 30 Days Walk to Success.
Okay.
It includes the whole reviews of modules 1 through 5. It includes the crash course review. It includes the question bank. It includes the diagnostic test. It includes the WhatsApp group. And as many times as you want to use me and ask questions, all that is included. It is not charging you for extras. The only thing that's extra is the flashcard, because they charge me exactly the same amount that I charge you guys.
And where is the crash? That crash course review that you were referencing yesterday? Where do we find that?
Is that Diana again asking the question, or somebody else? It's Diana, right? So I recommend that you do not look for it.
Okay.
I would say just do the modules as you are in sequence and attend the live class as they become available. Okay. Now, when is the next crash course review? I have to look at our calendar to answer the question. I think it's probably, I have to look, otherwise I'll say something wrong.
Next week, maybe?
Yeah, but it's coming up. It's the end of the month. Okay, so what we did is one crash course review every month at minimum. So that way, those that are testing in different schedules, they have the opportunity to attend a crash course review. And when that happens, it will be 2 days, Saturday and Sunday, and will also be lots of questions to do every day. Yeah, so it's very heavy in the work, super heavy. It'll be 2 days of 8 hours each, and we're only touching points on the most important stuff. But here's the catch. If we talk about Erickson, and we talked about 2 stages of Erickson, that is the other 6 stages that we covered during the module that you really should know for the test, because it's the most important test of your life. So when you come, that's why I say don't look for it now, but just continue on your track, on your way of completing the modules, because when you arrive to the crash course review, you will be ready to get the information. Okay.
Where do we get the Q banks, the question banks? Today is my first day, actually. My name is Gift. So
hello there, welcome. We'll send you an email with the Q bank. The Q bank is the only, well, the Q bank is not inside of the course, so you have to access another website, but you will receive instructions probably by tomorrow morning, on how to access. So once first thing you do is take your diagnostic test, which will be at the bottom of the page. And then from there, you come back and start the first video of the sequence, right? I want to share with you something, because this is a question that we always get asked. Where is the PDF? Right? So the PDF is going to be under the first video of each module. For example, module 1, the first video will be the cerebrum, and this is where you find the PDF for module 1, right? So what we did is, instead of giving you a 7 hours lecture on module 1, we broke that down in 23 micro lectures. So that way you can get on with your life, to the point, maybe do 2-3 lectures today, tomorrow you do 2 more, and you keep moving rather than having one massive 7 hours class on module 1. So here is your, let's say you are here when you first sign in, okay? Then you come down, and this is your diagnostic test here. Okay, that's your diagnostic test. When you complete it, just mark it down as completed.
And what's the passing score for the diagnostic? Sorry.
You have it. All you got to do is click it here, and I know you assess it. Okay, and then you come to module 1. After you come back to do the training, you go to module 1. And it is your video.
Hello, everyone, and welcome.
And then after you finish, look here. This is where the PDF is located.
Oh, perfect. Okay.
Now, let's look at module 2. If you go all trainings, and then you can go module 2. First video of module 2 is MSE, mental status examination. Click it.
I'm super excited.
And here is your module 2 PDF. And then, basically the course knows where you are, and every time you come back, the new video will be available for you, or the old video if you didn't finish. Now, I want to share this with you guys one more time. If you press here, see this right here where I am, there is kind of like question. Yeah, if you press here, this is not AI, this is me. So you can ask whatever questions you want to ask. If I covered in a course, most likely you get an answer. So what is the side effects of lithium? If I ever mention this, it's going to help you, right? Okay, here you go. I said, hey, side effects of lithium: hypothyroidism, weight gain, central nervous system. And then I said, hey, fine hand tremors. And I even said, this is high yield. Coarse hand tremors is a sign of toxicity, not a sign of lithium side effects. If you see coarse, it's toxicity. Fine hand tremors, you cannot see. The patient will tell you, but you cannot see. All right. So basically, these side effects can help differentiate between expected side effects and signs of toxicity. So this is me talking on the videos, and then the computer picks up and write it down for you. You can ask any question, and it probably will give you an answer. Now, if it's like something really outside the box, it's not going to give you an answer because I never talked about it, right? If you talked about which car should I buy, this or that, well, not going to have an answer because this is not AI. It's a recording of the lectures. And then if you ask a question, it's like, yeah, he said this on lecture number module 3, blah, blah, blah. And then it's going to kind of give you an answer. So use that for your advantage because it can be helpful. If you have a very daring question and you don't want to wait for the email, well, ask the assistants here, and they can ask you any questions we may have covered. Okay.
Okay.
Alrighty. So don't forget we have this community forum that you can use. 1 second, I kind of just kick myself out. You also can introduce yourself. You can ask questions, support other folks as they are learning through the progress. Why am I being kicked out? 1 second. Yeah, and if you have questions, this is a WhatsApp number for my WhatsApp to add you to the course on the WhatsApp. Okay, so you can send me a text via WhatsApp. I'll add you to the course. Now, people be on this chat 24 hours. If you are one that feels nervous when people are talking too much, it's probably not a good idea to be on that chat. But now, that chat can be also a teaching tool. Students helping students pass the board, right? Lots of good examples of how they remember something different. And it's all shared in our WhatsApp forum, okay? It can work both ways. It can work for your advantage, but it can also be a little bit nerve-wracking in some ways. Because if people are talking 24 hours, but there is a lot of good conversations in the chat, lots, every single day. Alrighty, go ahead. Thank you for your question there. Nikish, do you have a question?
Yes. So my question is this: for someone like me, particularly, that I'm not gonna be able to review anything at work because my work is so compressed, and I work in an urgent care, so I don't even have time to do anything. I'm gonna come home, I'm crashing here. So studying like 1 hour after work, I think is it gonna help me because I'm gonna be at a very slow pace?
No. It's going to help you, yes. What's the better way? May I suggest you something? Do 1 hour before work, right? You're paying yourself first by getting up, say, an hour and a half than what you usually do. It's only 6 weeks. If you do 1 hour per day, it's much more effective than doing 10 hours on a Saturday when you are off. 1 hour per day. And this is why we do small videos where you can do one lecture instead of doing 5 hours lectures, right? So do one lecture of 10 minutes. Look, this is maybe the longest video, and this one is 20 minutes.
Hello, everyone.
Like 25 minutes. So the next one, you go down, maybe 10 minutes. I don't remember. There you go, 14 minutes. So
Hello there and welcome.
So if you do that and download your PDFs, it's going to help you. Now, if you only have 1 hour a day, it may be that you may be in a course for 10 weeks or 8 weeks. And make sure that you are off for the live crash course review. Now, let's say, oh, Dr. Lopes, I work on a live crash course review. No worries. It is recorded and available for you right here, just like the other modules. So you have right here recorded by myself, and I also recorded the live ones that we did. You can watch this many times as your heart feels necessary. Okay. Now, it's one of those things. You have invested all this time, all this money into your education, attaining the PMHNP graduation, and here you are, just few days from achieving your dream. You may need to buckle up and really find the time to do it. Now, some people can do it without putting all the effort, and I applaud them, and I think that's great, but certainly is not the majority of us. Okay. Does it answer your question there?
Yeah, I just wanted to know because
Yeah.
I'm looking at it, it's overwhelming. I'm like, what time do
And
I
this
have
is
to
yeah, and
do
this
all
is
this?
why I don't
Yeah.
show all
Okay,
yeah,
license.
right. So I don't show, that's why I don't want you guys to go to all trainings. I want you guys to go homepage, one training at a time, one thing, right? If you go here, one training, that's all you're going to see. You don't see nothing else. Then you finish, you go down, and you go to the next training whenever you do have the time. Now, it is still a lot of content, but there's nowhere near what a big book would offer, right? Because the big book's going to cover everything. And then all you have to do is go through the videos once and then attend the live classes if you can. But most importantly, print your PDFs, because now you can take the PDFs with you. You did module 2 or 3 weeks ago. You're not going back to watch the videos. You have to read the PDF. You should read the PDF rather than going back to the videos. The videos one time and only, preferably, unless if you have tons of time, which is not your situation, one time, small videos to the point. And then if you can attend the live, great. If you can't, at least you've done one time. You just by myself recording the content without questions, without a lot of disturbance, to the point. Okay.
All right, thank you so much. That's
My
fine.
pleasure. Absolutely.
Mm-hmm.
Moray, you have a question?
Yeah,
Hi.
I was just asking how I can be added to the WhatsApp.
So Moray, send me a text to 808. Send me a WhatsApp text to 808-230-7858, and I will try to get it back to you soon enough, very soon. But I gotta answer my emails tonight and do a few things, and then once I'm done, I will go ahead and add you to the group. Okay?
Sorry, can you repeat that just one last time?
Yes. Yeah. 808-230-7858.
Thank you.
Absolutely. All right, folks, this was fun. We just finished module 2. If you are catching up, make sure you finish all the question banks on module 2 before we start module 3. If you are ahead, let's say you're on module 4, then come back to module 3 live event, which is always the same time, same days. Tuesdays, Wednesdays, and Thursday is questions. Okay. Last question here. Maya, do you have a question? Thank you, Kim.
Yeah, hi, Dr.
Hi.
Lopez. Yes, I was doing my question bank, and how many questions is there in module 1?
I think it's 147, 150, something like that.
In one piece, there's like 10. After, like, I try to go next and doesn't go. Like, it is
Well,
like my
let me,
computer.
one second, my dear.
Uh-huh.
Let me share with you the question bank, and then walk me through it. Okay.
Mm-hmm.
So 1 second, let me access my account, and then I'll share.
Okay.
So once you are logged in,
Mm-hmm.
1 second. So first one is 147, right? Question. So now I'm going to share with you and answer your question. So first thing everybody kind of need to understand is this X that's showing here. So if you have this X open, which is for questions, right? See the X here?
Where is X? A good
Do
God.
you see the X where it says got any questions?
Okay.
Do
Oh
you see
yeah.
it?
Uh-huh.
Okay.
Okay.
So let's say I am okay. Let's say I am. So first thing, if you do this here on the left hand side, it expands and contracts.
Oh, I didn't do that. That's why.
I don't know
Okay.
how to get to that. The PMHQ bank questions.
So this expands and contracts. Okay. So let's say you want to do advanced practice skills. So you go over here and click advanced practice skills.
Mhm.
And now you're ready to start. Well, let's pick whatever. And then let's submit. Oh my God, it doesn't submit.
Mm-hmm.
See that? Why? Well, this
Because
one actually did, but it shouldn't. This X here needs to go away so you can go to the next question. See here?
yeah, but like I don't think I'm on the right place still. So I'm in the like sample question. It's not the question bank, right? Module one sample question. So
No,
that is
so the question bank, you received that on your email and you got to log in.
yeah, I did that through email, and
Okay.
then I got a question bank.
Okay, so do you mind send me your
Yeah.
email in the text box here in the group? I'm gonna log in as you.
Uh-huh.
Put your email here, and I'm gonna log in as you. So I can copy and paste and be you.
Yeah.
That way I can have your experience and we can walk you through it. Okay.
Mhm.
Let me
Did
know
you-
when you okay,
Yeah.
I wasn't looking, so let me see. I got you.
sent-
All
yeah, I
right, so
sent-
give me a second. Let me log in as you.
Mhm.
Okay. 1 second. When I'm ready, I'll share my screen, sign out, log in. So 1 second, now almost there. I'm going to put your email and then I'm going to share my screen now. So I'm going to share my screen with you so you can see. Okay. See how I put in your email? Sign in.
Mm-hmm.
Right? So sign in. That's you. Okay.
Yeah.
Well, you got to come over here to log in. So you log in here on the right hand side.
Mm-hmm.
Log in. I'm going to put your email and I'm going to sign in as you. Once I do that,
Mm-hmm.
it says invalid email. It's because you have your own password. You have your own password, which I don't have it, but I can change that in a second for you and I'll give you a new password. So for the purpose
whatever you gave me, I put that one. I didn't sense it.
Okay. So let me use my own password here. Okay, 1 second, because, well, once you log in, let me change your password for you. 1 second, please, because I have to log in on my account now and change your password. Am I sharing this screen? I should not share it. Okay, I should not. I'm gonna shut it off for a second because I don't want to show the other accounts in here for your privacy. once I'm in, I will go ahead and, oh gosh, I'll go ahead and send you a password, your new password for you. So while I do that, is anyone else has a question?
Yeah, I don't have access to the Q bank as well.
Okay, you have to send me an email, and then I'll create one. You most likely do, because we already send you to you, but no worries. We'll go ahead and resend it with a new password for you.
Okay.
So, but send me an email to pmhnp@mpexamcoach.com, and then we'll go from there. So now I'm going to look at the student here, and then change her password. So that way, so it says here that your last activity was August 8th, and you were registered on July 15th. So let's go ahead and change your password, and then I will use that live so you can see exactly, so I can see exactly what you see. Okay, now I'm gonna log off, come back, log in as you. Here we go. All right, now I'm ready to share. Okay. So once you log in, you gotta go over here on the right hand side where it says log in.
Mm-hmm.
Click that. Oh, still thinking it's me, because I was still logging in my account. Let me. Okay, so I'm going to do something else. 1 second, guys. So this is like the computer's like, hey, you just log in as your account. Now you log in on somebody else's account and saving the password. Okay, going to a different browser here. Okay. So is your email address the same or that you provided for the course? Yes, right?
Yes, maya.dungana@yahoo.com.
Okay. 1 second. Sorry, it's taking a little bit longer here. Between your account, setting up your account, and myself, it's taking a little while. Okay. I'm going to go ahead and log in, and I'll share my screen when it's logged in. So once I do your password and I log in, and then now I should be just about in. Okay, I'm gonna have to go in the back end and do this for you, but for now I'll just keep using what I was using, and I'll take care of yours in a second. Okay? Because I would advise.
I'll see you next week. Thank you.
Yes.
Doctor. Okay.
See you next week.
Thank you, Doctor.
My pleasure. So I'm having a little bit of a issue here. Okay, anybody else has a question or concerned about anything?
Yeah, just shoot you an email, Dr. Lopez.
Okay, please do that.
Thank you.
Absolutely. And then Maya, if you want to stick around, we can kind of go over your stuff. I'm just going to stop recording so that way we are not sharing your stuff to anybody. So give me a